Hello, my name is Lori Maloy. I'm the Chief Clinical Officer, and I'm going to be talking to you about what it means to be a high reliability organization and to create a culture of safety. Hopefully you've had a chance to view the lecture on quality, and you recall that safety is one of the 6 key dimensions of quality. And in this lecture, we're going to be specifically focusing on the safety characteristic of quality. We're going to start out with the nightly news.
Dr. Donald Berwick, a Harvard-trained pediatrician, has dedicated his life to tracking a killer in a place that is supposed to make you well.
Where's the rapid response?
Hospitals are very dangerous places. I don't know how to explain this to the public in a way that doesn't create too much fear, but they need to be realistic. And the technologies that help you can also hurt you, and they do it every single day.
Dr. Berwick estimates that for every 100 patients admitted to hospitals, there are 40 to 50 incidents when patients are harmed, ranging from bruises and bed sores to much more life-threatening situations.
Between 44,000 and 98,000 Americans die in hospitals each year, killed by their care, not by their disease.
Do you hear from family members who say,
All the time.
My husband or wife or sister died and it didn't have to be?
My email is full of the most poignant stories that are surfacing from families, loved ones, patients themselves saying, this happened to me. Why did it happen? It didn't have to happen.
Stories like 18-month-old Josie King, who came to the hospital for burns but died from dehydration, and 27-year-old Joshua Nahum, who came in for broken bones and died from an infection.
You need to build a hospital like you build an airplane so that everything works right and that there's a kind of automatic excellence in the system instead of relying on human effort.
Dr. Berwick runs the Institute for Healthcare Improvement, and 2 years ago he launched the 100,000 Lives campaign. That's the number of lives he hoped to save by getting hospitals to have standard operating procedures for the way they care for patients, hooking up a ventilator properly to eliminate the risk of pneumonia, ensuring that a patient's medication is monitored from the ICU to the hospital room to home. Dr. Berwick says even something as simple as uniform hand washing requirements would cut hospital infections in half. So do you travel?
So when do you think that video was made? It was actually made around 2008, and we haven't made very much progress in creating a safe healthcare environment. To put this in a little bit more perspective, the number of deaths per year in a hospital is equivalent to 3 full 737 flights crashing every day with everyone dying. Would you take those odds? Would you book your flight today if you knew that 3 flights were going to crash and everyone on those flights were going to die? Hospitals are chaotic environments, and that's the risk for harm that our patients are in when they come to us for care. And we can't let that continue. The 250,000 deaths per year in the United States due to medical error. Medical error is the 4th leading cause of death in the United States. That question mark is there because it's probably the 3rd leading cause of death right now in the United States. We're not getting better, we're getting worse. And then the costs surrounding the harm that happens in hospitals every year is astronomical, $2.2 trillion. We have to get better. So please join me as we look through what it means to be a high reliability organization and what part you can play in lowering the risk for harm for the patients that present to Aspen Valley Hospital for care. This is the definition of high reliability organization from the book by John Nance, Why Hospitals Should Fly. A high reliability organization is an organization that has succeeded in avoiding catastrophes in an environment where normal accidents can be expected due to risk factors and complexity. If you haven't read the book, Why Hospitals Should Fly, I highly recommend it. It's an excellent book, it's an easy read, and it will change how you think about your job and how you provide care. Much of what I'm going to present and talk to you about in this conversation is I learned from John Nance. We're first going to talk about the power of speaking up, why it's critical for individuals to speak up, and why it's often hard for people to do that. So why is it hard to speak up in healthcare? Sometimes people feel afraid to be wrong or to look stupid. Sometimes people think, well, nobody else is speaking up, so I'm not going to say anything. Sometimes people have spoken up and they feel that they've been punished for speaking up, or they feel like they're tattletaling on somebody. They might have been yelled at for speaking up. Lucian Leap says the single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes. And I hope that's not true at Aspen Valley Hospital. We have worked hard to change that culture. But even though it's hard sometimes to speak up, it's one of the most important things that we can do, and we all have to be accountable to do it, even though it might be hard, even though we might be wrong. We have to be the advocate for our patients and families. And if we see something, we have to say something, because we might be right. And we might just prevent not only patient harm, but ultimately a patient death. This is called the Fatal Code of Silence. It's a true incident that happened in a Denver hospital.
So let's talk about a terrible case where something went very wrong because people were hesitant to speak up. July of 1993, young boy came into, 8-year-old boy came into a Denver hospital for a very routine operation to basically have a hole closed in his eardrum that was the after effect of having ear tubes as a child. It was a routine operation. They were going to take a cartilage graft, basically close this hole in his eardrum. I mean, this is about as safe a procedure as you can get. It's a simple case, 2 very experienced nurses, a very experienced anesthesiologist, but problematic because it was very intimidating, hard to work with. The nurses were essentially scared of him. Brand new surgeon who'd been there 3 or 4 months, had never worked with this anesthesiologist. And in the course of this case, a series of things started to go wrong. There were some issues around the breathing tube or the airway. There was a defective airway heater that basically started to overheat the child. And the team in the room, over the course of about an hour and a half, they kept identifying and addressing basic things that were going wrong. But they never got to any resolution about fixing them or actually saying, this is a problem, we need to stop, we need to fix this. And the whole thing cascaded that 2.5 hours into this operation, this little boy died with a temperature of 108 and a CO2 of 200. That was 5 times normal. And the really sad thing was when I interviewed the nurses after this, who I knew quite well. They said to me, we were just hoping, we were praying we would get out of the room with a child alive. Now you think about an environment where it doesn't even feel safe enough to pick up the phone, go in the substerile room in the operating room where the instruments are, and pick up the phone and say, could you have somebody come in this room because we're concerned something's wrong. That was a completely avoidable death. And in fact, there are some very simple things we can put in a culture of safety to say anybody, anytime they have a concern, they need to speak up. That'll be treated with respect. It'll be validated. We'll respond in the appropriate way. Do you think any of the people in that room are ever going to be the same? I don't.
That is an extreme example of what can happen if we don't speak up. And it goes back to some of the reasons that people don't feel comfortable speaking up, just with past experiences. But we have to get past that, and we just have to speak up in order to prevent harm for our patients. So in that particular example, what's the underlying cause of that sentinel event? Sentinel event is when someone loses life or limb. Is it because the scrub tech failed to insist that the anesthesiologist stop and assess concerns? Is it because the nurse failed to do that? Is it the culture not promoting safety as the highest priority? Or is it the anesthesiologist that failed to listen? Oftentimes I get people answering this with one of the people or the anesthesiologist. But the real answer, the underlying cause, is it's the culture of the hospital that allowed that behavior to happen. If we allow people to behave rudely and create a culture where people don't feel comfortable speaking up, then we say that's okay. And it's not. It is not okay. So what would you have done differently in that situation? I hope that you would have picked up the phone in the substerile room and called your next in command. That is what our policy is at this hospital. We have a chain of command. You start within the situation and you can go to your charge person or supervisor. If they're not available or you don't get the help that you need, you go to your director. If you don't get where you need to be from there, you can go to the administrator on call. And we have an administrator on call 24/7, 365. There is no penalty, no discipline for speaking up when you believe that someone may be in harm or you believe that there's a situation that needs to be fixed. You can go up the chain of command and you will not be penalized for that. It's also never okay for others to make you feel hesitant about voicing a concern. So if you are in a situation where you're very uncomfortable because somebody is continuously making you feel uncomfortable about speaking up, we need to know that as well. We need to address disruptive behavior so that we don't create a culture that allows that behavior to continue to occur. So in addition to the chain of command, we have standards for professional behavior for each of you as staff members. And in your orientation, you will have received those standards of professional behavior, and you will have been asked to sign that you have read them and that you will comply with those standards of professional behavior. For those physicians who are not employees of the hospital, they have a physician compact that defines those standards of professional behavior, and they are also expected to review them and to behave in a way that's consistent with those standards of professional behavior. So time out. What is a culture of safety? Is it a place where errors never happen? Absolutely not. Not even possible. We are all human and mistakes will be made. Is it a place where errors are always caught? The answer to that is no as well. There are things that happen all the time where we're distracted. We don't even realize what we did or didn't do. Is it a place where all staff can talk freely about safety problems without fear? That's what we're trying to achieve. But it's not a place where all staff feel comfortable reporting only if they're guaranteed anonymity. We have to be accountable to speaking up and to owning our part in creating a culture that is safe for our employees and our patients every day, every patient, every time. Now we're going to talk about some key elements of a culture of safety. The main characteristics of a culture of safety are psychological safety, mindfulness, active leadership, transparency, and fairness. Psychological safety goes back to the video that you saw that impacted that child's death. People didn't feel safe. They didn't have trust. They didn't feel comfortable speaking up. Are there people in your life that you feel comfortable speaking up to or asking anything? And why is that? What do you need to feel comfortable speaking up? That picture is me in the car and my husband driving. Every time I'm the passenger in the car, I don't like to drive, so my husband's the driver. And whenever I think that he's going too fast, or I think that a car might be gonna run into us, I speak up. And every time my husband says, "Do you want to drive?" And I say, "No, absolutely not, but I don't want to have an accident." I feel comfortable speaking up to my husband because I have trust with him and I have a relationship with him. In order to have psychological safety, we need to create relationships and build trust. We need to have our core values of teamwork and respect in our relationships. So in a culture that has psychological safety, what happens when someone speaks up? We say thank you. If they're right, we say, "Wow, thank goodness you spoke up. Please do that every time." If they're wrong, we say thank you. You might be wrong this time, but it was worth it to take a time out and just double check that everything is okay. So please don't hesitate to speak up. How we create a situation for people to feel comfortable speaking up is a two-way street. You own a part of that. How you do speak up in a respectful manner is as important as how the person responds in that situation. And the benefits of a culture that promotes psychological safety are the safety for all of us as employees and patients, and that we prevent harm, that we don't have avoidable deaths, that we don't have those little harms that occur to people every day, like a medication error because we became distracted or because we didn't follow the 5 rights of medication administration. So creating an environment where people feel comfortable and safe is what psychological safety is all about. The next component is mindfulness. Mindfulness has 4 parts: commitment to resilience, reluctance to simplify, sensitivity to operations, and preoccupation with failure. Commitment to resilience means that we're a continuous learning environment. It's not Chicken Little, the sky is falling when something bad happens. It's what happened and how can we fix it? You didn't hear any finger pointing or placing blame in what I just said. It's about what happened, what can we learn from that, and how can we do it differently the next time to prevent harm. Reluctance to simplify means that if we have systems or processes in place to prevent us as humans from making mistakes, that we don't create workarounds and not follow those systems and processes. We refuse to simplify. Sensitivity to operations means that you as new employees have a responsibility to know what our policies and procedures are at this hospital, and that you follow those operations. And finally, preoccupation with failure, we're going to take a little deeper look into. It's my favorite.
Nighttime, daytime, nighttime, daytime, nighttime, daytime.
What are you doing?
Having a game of nighttime, daytime. You want to play?
No, you're not.
Sometimes we put our blinders on and we see what we want to see. But if we change the way we look at things, the things we look at change. Do you see 4 sticks or 3 sticks? Or can you see both? Do you see a young woman or an old woman? The young woman's chin and the little tiny nose, or the great big nose of the old woman with her smile down toward the fur that she has around her neck? Some people can see both. Some people have a preference for one or the other. And to see both, it takes a while to be able to see the different perspectives. Is this cat going up the stairs or down the stairs? Some people will say absolutely up the stairs. Look at where the sides of the steps are. But if you Google it, it says there's no way to know for sure. The next slide I'm going to show you has a statement on it. And I want you to look at that statement and see if you see anything wrong in what's on that slide. Read the slide out loud. Most people, when they look at the slide, see a bird in the hand. It's because that's what we expect to be there. We assume that it says the saying that we're used to, a bird in the hand is worth 2 in the bush. But if we take a closer look and we have a preoccupation with failure, we actually see that the slide says a bird in the hand. So with preoccupation with failure, if you walk into a room and you expect to see a patient who has oxygen that's connected to their nose and that it's flowing at the liter rate that was ordered by the physician, and that they have an IV that's infusing in their arm with the correct fluid at the right rate, that's exactly what you're going to find. I'm asking that you walk into every situation and every patient interaction with a preoccupation of failure, that there's at least a 50% chance that something might not be right. If you do that, we at least have a chance of identifying potential harm, possibly before it reaches the patient. But if we go about without a preoccupation with failure in our daily activities, I guarantee you that harm will happen. So those are the characteristics of mindfulness. Active leadership is not about a title. Each of us are active leaders in whatever job we do. As active leaders, we need to encourage bidirectional sharing of information and briefings. So you, in your orientation, have to be an equal partner in that orientation. You need to share information with your preceptor and other staff, as well as receive information. We need to know the names of the people in the room and create relationships and a sense of familiarity. If somebody says to you, "Hey you," Does that make you feel comfortable with them? Knowing names of the people that we work with is a big part of creating a relationship. We need to set a positive tone. We can't control others' behavior, but we can control our own attitudes and our own behaviors. And we need to be open to creating relationships and open to having open and honest communication with others and setting a tone of acceptance or openness to hearing what others have to say. Active leaders share feedback and invite others to do so. They are approachable and they have a preoccupation with failure. I hope that you will all practice active leadership behaviors. Transparency is another key characteristic of a culture of safety. If mistakes are made and we sweep them under the carpet or we hush-hush talk about them behind closed doors, that doesn't do anyone any good. It doesn't help us learn from our mistakes and be resilient. So we have to create a culture with transparency where there's open and honest communication in an environment of trust and respect. We have to be a part of reporting good catches and sharing occurrence events. I send out a monthly summary for high reliability in the organization and share all the occurrence reports and the actions that we've put in place to prevent harm the next time. Not to point fingers and place blame. It's not about who did that. It's about what happened and what did we do to fix it? What did we learn from that? So speaking up and reporting when good catches or occurrences happen is a part of creating a transparent culture. Does that sound implausible? I hope not, because it's what's expected of you. When we talked early on about creating a culture of safety and why people don't speak up, we said that one of the greatest impediments was because people felt that they were penalized for making mistakes. At Aspen Valley Hospital, we have tried to create a just culture. In a just culture, it doesn't mean that there's no accountability for actions, but it does mean that we understand that we're all human and that we make mistakes, and that the first thing that we do isn't to punish someone for those. So in a just culture, you start out with unintended actions and unintended consequences, where we report the errors, we research what happened and how we can prevent it the next time. And we hope that we learn from those mistakes. In the just culture, though, we then move to intended actions and unintended consequences. So if someone repeatedly makes the same mistake, and we've put in systems and processes that are intended to prevent harm or to help prevent that error from happening again, and the person chooses to bypass those systems and processes, there's intended action there, and there's some accountability for ownership for what happens for that behavior. And that can mean anything from a performance action plan to additional orientation and training, but there is some accountability for that behavior. I'll give you a simple example. How many of you have ever gone above the speed limit? Myself included. I know that I'm speeding when I'm speeding. I know that potentially it could cause harm, and I am making a choice to go over the speed limit. An unintended consequence for me is if I get caught, I'm going to get a ticket. So again, I have to have ownership and accountability for my behavior if I choose to speed. Just as you have to have ownership and accountability if you choose not to follow systems and processes that are put into place to help prevent you as a human from making an error. On the far right side of a just culture is intended action and intended consequence. These are terminable offenses. One example of this is a scrub tech in Denver who chose to take the medication out of syringes for themselves and filled the syringes with water. This was eventually found because patients were having high degrees of pain following surgery, despite thinking that they had been given pain medication. Not only was that a terminable offense, that person was criminally prosecuted for their behavior. So in a just culture, we have increasing culpability. We understand that we were all humans and that we will make mistakes, but we try to put in systems and processes to prevent that from happening and to learn from the mistakes. And then in the middle, if we choose not to follow those systems and processes, there are some consequences for that. So in the just culture, we just looked at human error, at-risk behavior, and reckless behavior. And we teach our leadership to look at 5 questions when something happens. Did the individuals intend to cause harm? Did they come to work drunk or impaired? Did they do something they knew was unsafe? Could 2 or 3 peers have made the same mistake in similar circumstances? And do these individuals have a history of involvement in similar events? Let's apply this by looking at the anticoagulation case that happened in 2006. We had an experienced pharmacy tech who accidentally stocked a drug cabinet in the newborn ICU with the wrong dose of heparin. The cabinet was supposed to hold vials containing 10 units of heparin, but instead was stocked with vials containing 10,000 units of heparin. Heparin is a blood thinner. 5 nurses then administered the wrong dose to 6 newborns, and 3 of the babies died. In this case, do we have 6 people, the pharmacy tech and 5 nurses, who behaved unacceptably, or do we have 6 people set up to fail by an unsafe system? Let's go back and look at our just culture. Did the individuals intend to cause harm? Absolutely not. Did they come to work drunk or impaired? I can tell you they did not. Did they do something they knew was unsafe? No, they wouldn't have done it if they knew they were making that mistake. Could 2 or 3 peers have made the same mistake in similar circumstances? 5 nurses made the same mistake. And did they have a history of involvement in similar events? No. So what do we do in this situation? We have to learn from the mistakes. If we look at this through the lens of a root cause analysis and we ask why were there 10,000 units of heparin stocked instead of 10 units? We can start out by saying because the pharmacy tech stocked the wrong drug. And if we end there, we get nowhere in fixing this. The same person, a different person, could make the same mistake. Why did the pharmacy tech stock the wrong dose of heparin? Because the heparin was packaged in the same size box, with the same size font, in the same color. Everything was the same, but some extra zeros. Why? Because the manufacturer made it that way. Why? Because it was cheaper to do that. In this case, the result of the sentinel event of 6 newborns with 3 dying from this air was that the manufacturer changed the way that they packaged the drug. If we would have stopped at the 5 why, or the first why, was saying the pharmacy tech did it, we would never have gotten to the root cause of the reason that this event happened. Pyxuses were then created that only flip open to the dose that you push the button for. And all hospitals, including ours, put in a system where all pediatric medications and all high-risk medications have to be double-checked by either two nurses, a nurse and a pharmacist, or a nurse and a physician. So good things happened as a result of this to prevent it from happening again. But if we didn't have a culture where people were free to speak up, and a culture that was resilient and could learn from its mistakes and put in systems and processes to help prevent errors from happening again, the same thing could have happened over and over again. So time out. If we go back to the fatal code of silence where the young child died, and we've talked about our key elements in a culture of safety, which one of those was missing in that death of the 8-year-old boy? It's psychological safety, right? Something that we can fix. We have to create an environment, a culture where people feel psychologically safe to speak up. Now we're going to talk about some of how you can contribute to a culture of safety. The key ingredients we're going to talk about are teamwork, communication, and patient-family engagement. And our goal for our patients is zero harm.
It's smarter to travel in groups.
Teamwork, it's our core value, 1 of 5. There's no I in team, right? Or is there? Oh, yes, it's the a-hole. It's that person that's disruptive, that causes a lack of psychological safety in situations, right? Or is there a place for the I in team? Think about the code of silence. What if one person on that team had the courage to speak up? I am not asking you to just function in a group. Have you heard of groupthink, where everybody just goes along with what one person says? In a culture of safety, I need you all to be accountable for speaking up when you think that something isn't right. I need you to be accountable to allow people to speak up and to be open to the fact that you might be doing something not in the right way. I want you all to be individuals, to come with your knowledge and your skills and to practice with a preoccupation with failure and to be the first one to see the second "the" in a situation and to speak up because it's the right thing to do to prevent harm. So there is a place for the I in team. And I hope that you will all be that I when the time is needed. Communication. I say to my husband, go to the store, lay down the mulch, wash and wax the car, get the kids to school, rent some videos, and finish the rest of the dishes. And what does he hear me say? Oh, go lay down and get some rest, honey. I'll take care of everything. When we look at the reason that errors occur, communication is the number one reason why errors occur in hospitals. So we have to think about some specific ways to improve communication. One of the things in psychological distance, sometimes people describe that as reducing power distance or hierarchy. There is a perception in healthcare. I know when I got out of nursing school that I was taught the doctor says jump, you say how high. That's not the way it is anymore. We are one team. We are equal partners and we all have value. So we have to reduce that power distance. And when somebody speaks up, we all need to listen. And it's not just doctor to nurse. What about nurses to techs? And where are the housekeepers and the people that work in the cafeteria and the schedulers in all this? We each have an impact on each other in creating or eliminating a power distance or a sense of hierarchy in this organization. Another way to improve communication is to use structured communication. Have you heard of SBAR? It stands for Situation, Background, Assessment, Recommendation. It's a way of framing the conversation so that people are listening and knowing what to expect next. Often when we talk to people, we just say what we're thinking, but we don't get to the real point, and that's what's the recommendation. So we call a doctor at 2:00 in the morning and we say, hello, Dr. So-and-so in room 105 is, their blood pressure's a little bit low. Okay, thanks. Call me in the morning. If we call the physician and we say, doctor, this patient was admitted at 10 o'clock this morning, their blood pressure has changed from 120 over 80 to 220 over 110, and I believe they're having a stroke, and I recommend that you get in here now. I have a much higher likelihood of having that physician respond and come in and do what I need them to do than if I don't use that structured communication. So I highly encourage you to use SBAR communication. It has been proven to be very effective, especially in the healthcare environment. We do huddles and briefings. We do a morning huddle every day at 8:15 and every evening at 8:15. We do that so that we're communicating and people know what's happening in the hospital. If we've had a forest fire and everybody needs to know what the plan is, we need to have huddles and briefings to keep people informed. Those who attend those safety huddles in the morning should be going back to their department and sharing what they've learned within their department. We do debriefings when something has happened, such as a trauma or a code, so that we can learn from that and be resilient. It's not about pointing fingers or placing blame in those debriefings. It's about learning what we did well and celebrating. What did we learn? And what should we do differently next time so that we're a continuous learning organization, which is part of being a high reliability organization, an organization that people can trust when they come to this hospital, that we will provide extraordinary care and that we will have done everything that we can to prevent harm for that patient in creating an environment where there's strong communication, a preoccupation with failure, we're resilient, we know our systems that are in place, and we have a sensitivity to operations. We have psychological safety, we have transparency. And in those briefings, we learn what we should do differently next time. And then we implement that and we share that knowledge. Another means of communication is called CUS. CUS or CUSS. So yes, you are allowed to cuss at Aspen Valley Hospital. CUS stands for a concerned, uncomfortable, safety issue, and stop. It's an escalated means of conversation, much like in that video of the young boy that died. The staff could have started out with, "Excuse me, doctor, but I'm concerned that there's something not right with this child." If they get no response, they move to, "I'm uncomfortable in this situation. I feel like there's something not right. We need to." If they get no response, "This is a safety issue. I'm concerned that this child is not breathing well. There's something not right. We have to stop." So cussing is a way to communicate in an escalated means that everybody needs to listen and stop and check on what's happening in that situation. "20 things we should say more often."
20 things we should say more often. Number 20, thank you. And not just on Thanksgiving, every day. Number 19, excuse me. Number 18, here's a surprise corn dog that I bought you because you're my friend. There'll be more corn dogs and more happy people. This is a good idea. Corn dog for you, corn dog for you, corn dog for you. Number 17, I'm sorry. Number 16, I forgive you. Number 15, you can do it, but don't say it if it's something I can't do. Number 14, another thing that we should say more often, I have barbecue sauce in my shirt too. Before you say something about the barbecue sauce on somebody else's shirt, take a look at the barbecue sauce on your own shirt. Number 13, please. Number 12, everything is going to be okay. Number 11, oh, you got me a corn dog too? You shouldn't have, buddy. Number 10, I don't know. I know a lot of people who need to say that. My sister. Number 9, you're so awesome, I named my dog after you. Wait. That could hurt someone's feelings. I mean boat. I named my boat after you. Wait, who even has a boat? You're so awesome, I legally changed my name to yours. Wait, that's super creepy. And just tell people they're awesome and mean it. Number 8, hello, person that I've never met before. Here's a high five. Number 7, my sports team is not always the best sports team. It takes a big man to say that. Number 6, nothing. Sometimes that's the best thing you can say. Number 5, doesn't mean anything, but it's just really funny. Number 4, I disagree with you, but I still like you as a person who is a human being, and I'll treat you like that. Because if I didn't, it would make everything bad, and that's what lots of people do in this lane. Whew, I need a water break, y'all. It's okay to disagree, but it's not okay to be mean. Number 3, sometimes you just gotta scream. Number 2, life is tough, but so are you. Sometimes we all need to be reminded to keep going. Number 1, something nice. Anything. If you can't think of anything nice to say, you're not thinking hard enough. So what about you? What do you think people should say more often? Leave a comment below and let's hear it. Oh, and I got a bonus one for you. Something that we should say more often? Let's dance.
A couple things that I love in that video. One, again, I hope you will bring joy to work and have fun at work and laugh. If I have barbecue sauce on my shirt, I definitely want you to tell me. It's okay if you don't have it on your own shirt. And then we've spent an awful lot of time talking about speaking up, being accountable to speak up, the importance of speaking up. And he says sometimes you should say nothing. I do want to say that it is important to speak up at the right time. If you're in the situation where it's life-threatening, you need to speak up right then and there with everybody in the room. And that's the right thing to do. But if you're just having trouble with somebody in your communication or how they made you feel, or there's something that they did that you need to talk to just them about, do that at the right time, privately. Have a one-on-one conversation. You need to make sure that you're in the right frame of mind to have that conversation, because sometimes we're upset, and if we try to talk about it at that time, we say things in a way that just don't come out right. So sometimes it is important to say nothing at the moment, but to get your wits about you, get calmed down, and have a conversation in private at the right time. The last thing we're going to talk about is patient-family engagement. It is so important that the patient be a part of their care and that the patient is at the center of their care. The needs of the patient come first. Nothing about me without me is what the patient would say. Every patient is the only patient, and enter the patient's world and see the situation through their eyes. We know that the patient is at the center of our strategic plan. And when we talk about creating psychological safety and the potential for power, distance, or hierarchy, where do you think that patient and their family feel in that hierarchy? Oftentimes, they feel at the bottom. They don't feel listened to or heard. I can tell you on the Patient Family Advisory Council at Children's Hospital in Denver, I got to hear 3 mothers speak of their experience. They joined that committee because each of their children died in that hospital, and they didn't ever want that to happen to anyone else. So they became part of the committee to help others in the hospital learn about the importance of including the patient and family in care. Each of those mothers tells a heart-wrenching story of speaking up and not being listened to. Hey, I'm worried about my child. Oh, they're fine. They're fine. We've got this. You just go relax. Next shift. You know, I mentioned this earlier, but I really think there's something wrong with my child. They're not acting the way they normally do. Oh, they're in the hospital. They're okay. We checked, and their blood pressure's okay. They're fine. Every one of those children died because the family members weren't listened to. They weren't an equal part of that team. We have to have that preoccupation with failure. We can't go in and assume that everything that's happening is exactly the way that we think that it should be. We have to make that patient and family the center of the care and an equal member of the team. We need to personalize their health care. They need to be involved in self-decision making. We need to teach them how to manage their care. We need to have the skills and knowledge to care for them, and we have to have their participation in care. So please help in creating a culture of safety at this hospital. Remember those 3 tiers to human safety. Be an equal part in your orientation and competency training. Learn our systems and processes and operations. Come to the hospital with that active leadership perspective and a positive attitude and help create a collegial team. And never, ever, ever have an expectation of greater than 50% success. Creating a culture of safety is everyone's job. We all have an accountability to speak up, even though it might be hard, even though we might be wrong. We have a responsibility to create relationships. We need to inspire others, focus on understanding processes of why things fail, not pointing fingers or placing blame, and learning from our mistakes. And if we can do these things, zero harm is possible. So let's create a culture of safety. I assure you it will be worth it, and I welcome you to Aspen Valley Hospital. Thanks for joining our team.